Welcome to the Behavioral View. I'm Nissa Van Etten with my co-host Olivia Teal. Each episode, we will talk with practitioners, researchers, and leaders about the work of behavior analysis, how we understand it, how we use it, and how it's evolving. We take a straightforward look at the field, what's working, what's challenging, and how our decisions shape the work we do. Thanks for being here. This is the Behavioral View. If you're looking to earn a CEU, just listen to the full episode and then complete the short quiz that follows. That's all it takes. Hi, everyone. Welcome to Season 6, Episode 2 of the Behavioral View. My name is Nissa Van Etten, and I am the host of the Behavioral View, joined by a number of wonderful colleagues here at Central Reach. I'm going to go ahead and let everyone introduce themselves, and then I'm going to take a minute to kick us off. So I'll turn it over to you, Olivia.
Sure. I'm Olivia Teal. I'm an ABA content developer with the Institute, and I'm excited to chat today.
Hi, everyone. I'm Elizabeth Barajas. I'm a clinical AI solutions architect and content creator at Central Reach.
And wanted to introduce and welcome to the panel today our new colleague, Yagnesh. Why don't you spend a few minutes introducing yourself and talking about yourself as you came to Central Reach?
Happily do so, Nissa. Thank you so much. And to my colleagues on the call, thank you for the opportunity. I'm really excited about this. Yagnesh Vadgama, BCBA by training. I always feel somewhat excited and yet shocked when I say that this will be my 22nd year in ABA. I started doing ABA when I was an undergrad at UC Irvine. So shout out, Nissa. It's very rare that I have fellow anteaters on the call anywhere. So
yeah, I think there are two of us because Elizabeth is one too.
Oh, Trini. Hey, where you going?
Yeah.
Nice. Wow. This is definitely very rare in my law. You get this like caught off guard here, right? I was like, 3 years. So I started doing direct intervention work when I was at UCI, stayed in the master's, BCBA, program director, clinical director. And then 11 years into the game, I started really asking myself, how can I start to make a difference at a more of a macro level? And I was really fortunate that I went from there from the field to Beacon Health Options, which is now Carelon. And I was there for a year, focusing primarily on the Medi-Cal product that Beacon had. And Medi-Cal is Medicaid in the state of California. The regional center, if you're familiar with the regional centers in California, the regional centers had just shifted from their responsibility over to the managed care organizations. And so as a part of that, it was a very eye-opening experience. And then I made the jump from there over to Magellan, and I just wrapped up over 10 years at Magellan, where I started as the director of autism services, but then worked my way up to becoming the VP of autism services, served as the organization's SME for about 15 million members who had the autism or the ABA benefit across Medicaid, commercial, and employer plans. I led a team of about 45 clinicians who were doing the prior auth UN review. And in addition to all that, I was also the president and CEO of the California Entity Health Plan for Magellan, which is HAI California. So wore several different hats. And why that's important in context for this conversation here is because it really helps to bring in a broader health plan perspective plus clinical background here to Central Reach. And so I joined Central Reach earlier this month as the VP of Payer Strategy and Network Management. So I'm also part of the CR Institute, working really closely with Dr. Tom Frazier, Allison Frazier, and Ling Zhao on how can we advance outcomes-based care in the field of behavior analysis.
Ooh, that is a hefty intro. Thank you for going into that. And we are going to really unpack that with a number of questions. We all have done a little brainstorming. We have a ton to ask you today. And a lot of it comes from our perspectives as behavior analysts and questions that we imagine the field would have as well. But before I dive in today, I do want to acknowledge just a little bit of shift that you see on the Behavioral View today and a transition from our previous host, Dr. Shannon Hill, who was the individual who brought this podcast to life and guided it in its vision for the last 6 seasons. Dr. Hill has moved on to new opportunities, and while she's continuing to dedicate her passion for diverse voices in the field of behavior analysis, we as a team just want to congratulate Shannon, thank her for all of her contributions to Central Reach and to the field. So I wanted to do that kind of before we jump in, because I know our viewers are going to be interested and have some questions, and we're hoping to be as transparent as possible. But going back to Yagnesh, what you were talking about, your trajectory and your background and experience, while we all may have started at UC Irvine, or some of us, most of us on the panel today.
I'm glad we're out here.
We are in a new world of behavior analysis, and that shift from what we've seen. There are so many different ways we as behavior analysts can use the credential, the training, and the experience. But following in Dr. Hill's footsteps, one of the things she loved to kick the podcast off with is a question of the day. For today, our question of the day, I don't want to say a leading one, and I think everyone will have a different answer, but if you had to explain outcomes-based care or outcome-based care to a BCBA in one sentence, what would you say? And anyone can start.
I've got one. I had to think about this because I'm not the most concise speaker. So I was like, let me keep it concise. I would say putting effective at the forefront. When we think about the 7 dimensions of ABA, putting the effective dimension at the forefront and really making sure that we're all as a field holding ourselves accountable and looking at that. So
putting effective at the forefront. I like it.
I like that too. Being concise is hard. I agree. I was like, I could do it in maybe a paragraph, but a sentence is really difficult. So I would just say that, the focus on measurement and progress, whatever that may look like for the individual learner.
Yeah, if there was an option for me to say C, all of the above, I would say that as well. I think outcomes-based care, in addition to what has been said here, outcomes-based care, from my vantage point as well, has to be driven by how can we deliver care based on the empirical evidence that's in front of us. And I will give an incredibly shameless plug here to Central Reach, because the team in the organization and the minds that Central Reach has been able to amass over the years to be able to come to this very moment. And outcomes-based care at Central Reach is not just solely based on Tom joining last year and then me joining in February. It is content creating, it is clinical driving, it's having conversations with clinicians, it's training for this moment that we're now seeing in front of us. And we'll talk more in these conversations, but our industry is really at a crossroads right now, and outcomes-based care has to be the way that drives us forward.
I like that. In hearing all of yours, I want to change my sentence, because I think when I hear outcome-based care and I think about outcome-based care and what I've learned in the last few weeks, really coming up to speed with it, my sentence would be allowing clinicians or behavior analysts to do the work they were trained for is really what I imagine and conceptualize when someone says, why would I want to do this? What is it going to do for us? And hearing all of the different vantage points, it makes me think that means we get to do what we are trained to do. We get to actually focus on the learner and improving their quality of life and their skill sets and their family's quality of life. So that would be my sentence.
Perfect. Something I was going to say that I think sort of surfacing is that whenever I do hear that term, I do immediately think of insurance. And I think about how there's a lot of discussion about how organizations need to be better aware of how they're doing as an organization. And that relationship with insurance, as it's becoming more, I think there's wanting to be more understanding and transparency about how the organization at large is doing, maybe even compared to other organizations. So that's just something that I immediately think of when I hear that term.
So organizational health is one big component that you're thinking is related to.
Just immediately, just because there's a lot of discussion about that as it relates to just services and insurance.
And kicking this back to you, Yagnesh, because you are our in-house expert now, and I think a lot of our listeners are really excited to see you join the team and to understand what your role will be. We heard your title, VP of Payer Strategy and Network Development, but I would love to just level set for our listeners, for those BCBAs who really don't understand what outcome-based care is. Can you define it or differentiate it from the traditional fee-for-service model that most of the BCBAs out there are used to?
Yeah. It's a great question. And really, it's something that I grappled with when I was at Magellan for over a decade. But something that I struggled with at Magellan and was in a very unique situation in sitting across not only health plans across the country, but also state regulators and federal administrators around how should the ABA benefit be administered for its recipients. And through my experience working for the MCOs, for the managed care organizations, through that time was when all 50 states eventually got the autism mandate or the ABA mandate passed across all 50 states. So you started to see that happening in each state. And the science of ABA was well ahead of where the payers were. And there's many reasons why the payers weren't ready for that. But the truth is the payers weren't ready for it. And so they were ingesting these requests and taken it as, okay, we're going to accept this. But then over time, the payer started to ask the question around, what are we really getting for this?
Yeah.
We're approving this, but what are we getting on the back end? Are our members doing better? Are our members making progress? And I appreciated you setting with, okay, what is outcomes-based care and how does that pertain to your particular title, Yagnesh, and what we're going to be doing here? The ABA is built on that single subject design. And so when a health plan says, or anybody for that matter, it doesn't have to be a health plan, says, is this individual getting better? Is this learner getting better? We can look at that one individual and ask that question and say, yes, no, or tell a story in between. But what do you do about a whole population? What do you do about everybody on a particular health plan? What do you do for everybody in a particular state? How do you know that ABA truly is effective? And so through outcomes-based care, we're able to take a step back and reimagine in more of a group design. And so we're able to see at a group design level, are we truly making progress for those particular providers or for the particular plan? And can we standardize the way in which the delivery model is given based on the phenotypic profile of the individual? And so putting all that together can help us to get a more illuminating story. It could tell us about what the true validity is of how we're progressing, while simultaneously, truly, in my opinion here, giving us an opportunity to defend our science. Because there's a host of reasons why our science is under fire right now, and we all feel it from different angles, right? Yeah. And so by being able to say, yes, we're delivering high quality care and here's our outcomes. And yes, we're delivering it because here's the empirical evidence by which all the programs that which we're providing here, the goals and the direction and the place of setting and the hours, et cetera, is empirically backed. And here's the research that supports that. That gives us greater validity for those external stakeholders who are ultimately funding these programs.
I think that's really interesting to distinguish that single case design versus group design, because obviously with a fee for service model, you are still showing progress. I mean, that's what the reassessment is for every 6 months, typically. So I think that that's really interesting to think that the outcomes-based care model is shifting to look at kind of a larger scale of progress rather than like the worker annual, every 6 months, and it's not standardized. Everyone's doing different assessments. Everyone's doing measurements. So I like that you made that distinction, because it's not that fee for service isn't looking at progress, because we are, it's just looking at it differently, it sounds like.
That's right. That's right.
Well, that leads me to ask and to wonder about our measurement type. What types of measurement will outcomes-based care be looking at? What are they going to be requesting, especially if we're looking at more of an aggregate level of reporting? What's that submission, or what is the organization supposed to prove or share with the funder to ensure that we are a part of this outcome-based care model?
Yeah, again, I'm going to keep coming back to the science and literature, right? And one of the many beautiful parts of our science and behavior analysis is that our science continues to be evolving each and every day with new articles that are coming out. And we are at a place as well with Essential Reach that is also pushing that research, right? Yep. Whether it be Dr. Ray Cabina, whether it be Dr. Tom Frazier, et cetera, right? And so while leaning on that literature to help guide what that treatment modality or outcomes need to be, it helps to give us a vantage point really into seeing, is the treatment modality effective? And if it's not effective, and I think this is one of the challenges that we've had as behavior analysts, right? Where there's almost a sense of martyrdom that which we carry, and it's pride. It's something that we all have, right? It's the deeply passionate caring that we have. This is before we started recording, right? You jumped on it right away. You started talking about 2 clients.
Yeah.
And that speaks volumes of who we still are at our core, right? That how much we truly care here. And how can we demonstrate to those external stakeholders that care is being delivered through what the empirical evidence is? And historically, we haven't been doing that. And historically, what we've been doing is leaning on either the cultural background or the educational background of our mentors at the particular provider group. But that's one provider group and their approach. And then you take the thousands of provider groups across the country and they have different approaches. And again, I don't want to besmirch what we've done historically, because again, I did this for well over a decade when I was in the field. How can you create standards here in the same way that, frankly, to be very blunt about this, all other levels of healthcare do the same exact thing.
Yeah.
So through outcomes-based care, we can create that standardization and that predictability.
That makes me wonder, in the standardization, will that include recommendations for assessment? What type of assessment should be utilized? What does the assessment process look like? Is that something that behavior analysts are, especially being a field of a large percentage of newly certified professionals, new professionals in the field, just trying to understand what is assessment? What does an assessment process look like in an outcomes-based care world?
Yeah. And one of the beautiful parts about outcomes-based care and giving the structure for what is needed here, it really helps, right? We all hear the stats, right? 50% of the BCBAs passed the exam in the last couple of years. And those numbers are only increasing exponentially, especially now with the rolling tests that the BACB now allows, right? And so it's important for us to be able to clearly identify and capture through ongoing assessments what the true clinical need is of the individual. So if we take a step back from behavior analysis and look at autism overall, 70 to 80% of autistics have some kind of a physical and or behavioral health co-occurring condition. And I can say with great clarity, working at a health plan and seeing thousands of authorizations being processed each year, tens of thousands, we would be lucky to see between 7 or 8%, let alone 70 to 80 that had a co-occurring condition. And again, behavior analysis, it's visual analysis. You're able to see visually with a visual representation. Are we making progress, yay or nay? And so you would see great variability in the data, but never a step back to say, maybe there's a concern around sleep or quality of life or social determinants of health, or are we being culturally sensitive to what the family truly needs? And we can only deconstruct the practice so much before you just say, let's just be parsimonious about this and say the simplest answer is the best answer. And the simplest answer in this is ongoing screenings and assessments for us to be able to capture and identify what the true clinical need is.
Yeah. So what does that package look like? Is that still very much like we see today, an individualized nature of I'm BCBA and these are the assessments I choose that I've been trained in, and this is what I submit? What does that look like for scale in terms of outcomes care?
What that means for scale is from where we're trying to go is by giving clinicians a standardized practice of care that which they can consistently and reliably lean on that will help to tell them, hey, based on the individual's needs, these are the goals that should be recommended. Based on the deficits, here's where you need to really focus in on. Speaking to all the clinicians, not only here on this conversation, but everybody outside of this, as you're listening in, how many times have we just taken the same cookie cutter goal set and applied it to everybody?
Yeah.
And what really shifted my view on all this is, again, working in a health plan and seeing goals recommended that had no place in medical necessity. Things like teaching an adult to go to a cocktail party and have a conversation. Teaching a 19-year-old how to throw a ball. That's fine leisure skills, but does that truly meet medical necessity?
Yeah.
Or, I can say this as a parent with 3 young children, a 4-year-old not having a tantrum. I can't even go a day without my kids having a tantrum, right? And yet we see this all the time. And so it's important that we're able to guide this industry and our science to say what's really needed.
Yeah.
And what would you say to a clinician? Because I feel like the role that we're all playing here is curious clinicians who are dying for information. Like, I don't understand. How is this going to affect my process, my clinical process? What would you say to a clinician that is nervous that they're going to lose control over getting to pick their own assessments and getting to pick their own goals for their client based on their client's individual needs?
You will still have the ability on how you implement it, right? In the same way that a surgeon knows that they have to perform shoulder surgery, right? The book says you're going to do shoulder surgery every time, depending on how much it is a tear or what the rotation is or what the end goal is, et cetera, right? At no point is a surgeon going to say, hey, let me just cut you open and let's just see what we could do here. And we're all going to do it differently. It has to be consistent. And I know that the counter argument oftentimes is behavioral health is different. And surely it is, right? But CBT performs, right? Even ECT as examples, right? Behavioral health services, it's all consistently delivered. And so you can have the structural framework, for instance, on, like, you take AIM as an example, right? AIM can guide you on what the goals need to be, but it's your responsibility as a clinician on how you're going to implement that, how you're going to work with the family, how you're going to train that RBT, how that RBT is then going to deliver this, how you're going to gain instructional control, what the reinforcement schedule needs to be. Now you can get into the nitty gritty of behavior analysis, the stuff that we all love that helps us to be able to shape and work on environmental manipulation. Absolutely continue to do that. But the overall structure around here's what the deficits are, here's the goals that need to be addressed. Take care of that, and we can start to see the tremendous amelioration in this young individual's lives.
Yeah, I think that's really helpful. Thinking about it like the learning trees, if you're using Central Reach, like you've got your assessments, you've got your goals, but then when you go into the targets and, like you said, the behavior intervention strategies that you're using, those are individualized and they're going to be shifting depending on what's going on day to day.
And I love, Olivia, that you brought this back to probably what a lot of our listeners are experiencing, and just curiosity, right? This is a topic that's been out there. I know for the last few years in different roles in different organizations, this conversation has come up, is what is the best outcome for individuals with a diagnosis of autism or IDD? Do we get to determine that as a group? Do we get to determine that as a profession? Is it up to the funder? We're at a place in time in our field where it is important that we do look at outcomes, that we don't keep all of our learners in ABA services if it's not necessary. If we can get them into least restrictive environments, it's really important we do. But I think the curiosity component is, what is the change for me as a clinician in my day-to-day, my practice, right? My data collection likely looks the same. My interventions are based on the science, but truly and we can clear this up, maybe start to clear this up here, is my experience is every 6 months, I send out a Vineland, I start my assessment, whether that be the VB map, the ABLs, the AFLs, and then I gather the data and I report according to progress. And sometimes progress is great, right? We have tracked everything in the right direction. We can move on to the next goal. And sometimes progress has stalled and I'm not sure where to go next. So I think a lot of our listeners will really be cued into, what is it going to look like? How do I learn more? How do I get involved at the individual level in terms of learning? And then how do I get involved at the organization level? Because I think organization leaders are going to have different questions than BCBAs that are working within those orgs. Loaded question there. I think training. I know, Yagnesh, we talked a little bit about getting you involved in creating some training for our listeners and Central Reach customers here in the Institute. What does that training look like?
That training has to be ongoing. And it's similar to that of when we're in ABA and we're providing supervision, right? Supervision has to be ongoing. And also part of our supervision practice is making changes in real time. And that's where training comes into play as well. And I also firmly believe that part of that training also has to be being open and honest and allowing ourselves to become vulnerable in this, right? This is going to be a shift in the way that which we practice day to day through this transparency, which we want to be able to provide, right? We have to be able to have a higher level of transparency around what does progress truly mean. And in an ideal state, right, we would say everybody has ABA for a few years and then they graduate, then they're off to gen ed, and then we get a letter from that parent when they're 17 years old that they're off to college, et cetera, right? That's not the reality for everyone.
No.
Right. And so what does progress look like for everyone? And that part is going to be individualized. And that part, we have to be able to accept that progress may be, we've reached the maximum level of progress with ABA services, and it might be time to transition to something else, whether it be vocational or respite services or transitioning to a school service. And so again, having those ongoing conversations around both progress, and again, that's not going to be held against you, which I think has long been a fallacy of our industry. If you're not graduating for progress, that you've somehow failed. And that's not right.
Yeah. I think that's such a good point, because I think that we've got learners across the spectrum, across the board, in terms of our listeners and who they're serving and who they're working with. And one of the conversations I've had recently with a colleague is those kind of transitional vocational rehab type services, right? We know that population that continues to grow and need our support, but the conversation leads to, where's the funding what do those goals look like that are effective? And then how do we ensure that our colleagues are prepared and trained to work with that population? And this might be a question we don't have the answer to, but what does that look like in this model?
Yeah. Also, just to backtrack a little bit, you've also got me thinking about dosage recommendations. Just curious. I'm sure there's others that are probably curious about what that might look like as this moves forward. Just throwing that out there.
Sure. And tackling both, right? On the dosage recommendation, it is an output based on the research and the literature. And so bringing that all in together, and again, this is through Dr. Tom Frazier's meta-analysis on what the dosage and the recommendation needs to be based on progress or the phenotypic profile, providing that to the clinician who can then utilize that information in their recommendation to a health plan. And my job is to disseminate that to a health plan to say, you don't need to focus on denials. You don't need to focus on delays in care based on what the recommendation is, because if that recommendation is coming to you based on empirical evidence that has been peer reviewed and published, every time you give a denial, you have to back up the denial with some kind of a literature or a justification as to why. And so the health plan, theoretically, would have nothing to back that up against on a denial if the output, again, has that empirical evidence behind it. And so that is the structure by which would help to guide the clinician around the approvals and the denial process and making sure that this is now a seamless transition to getting care covered.
I think that's so interesting. I think that a lot of times we think of the payer and the clinician as on opposite sides sometimes, having different opinions or things like that. And so thinking about it as outcomes-based care potentially being a way to bridge the gap and bringing them onto the same side, for lack of a better word, because we're both looking at the same literature, we're both looking at the same evidence, and we both agree that this is valid and a valid approach. So I find that to be valuable if that's the direction that it's headed.
Yeah, Olivia, and I appreciate you saying that. I take pride being a BCBA, and I think it's also really important that I say I took a lot of pride in trying to be a part of the solution, and that I believe that the best way to make noise about the system is in the system, which is why I was at the payer side for over 10 years. And while I was there, we had the denial rate of less than 3%. Wow. And so that denial rate, even within that 3%, was, I can count on one hand the number of times in my over 10 years that we ever gave a full clinical denial. It just never happened, right? Because you want to be part of the overall solution on how to drive care forward. But it was a very labor-intensive work around having a clinician on one end, being that liaison with that provider and the authorization on the other end to say, in order to get to that authorization, here's all the things that which we need to do. Very labor intensive. Now, how can we instead use tools and technologies, and to be very honest, CR enterprise tools and technologies to help guide how to get through to that other end so that you're not having to get hung up on the approval and denial process.
Mm-hmm. Yeah, we're already in agreement on the direction that we're going before we even put in our first request.
Exactly that. Yeah.
I want to pause. One, I had to shift the lighting here. It's getting, sun is coming in, so I apologize for that. But two, Yagnesh, thank you for answering these questions. We have so much curiosity that I hope you understand that we are just truly trying to understand and probably ask the questions on behalf of some of our listeners who are very much in the same experience as ourselves of just, okay, this is maybe a new shift for our world, right? ABA may be moving in a new direction. And with change comes a lot of curiosity, questioning, trying to understand how it impacts us. But I want to go back to one comment or this conversation about the literature. So I have seen in previous lives where people do add an entire citation section to a treatment plan, using the evidence in terms of how they're making recommendations for interventions, goals, teaching plans, but not mapped to the outcome of an assessment. Or are we talking here about utilizing a specific assessment, AIM as the example, as with the dosing and strategy component of AIM, as one of the exemplars of how we may be moving to talk about outcomes-based care because the AIM tool was built on that type of evidence and the aggregate level of reporting that we're talking about, using the growth scores and some of the data that Dr. Frazier had access to.
Yeah, that's right. That's right, Nissa. That's right.
Okay.
And if I'm being very honest, right, it's a fun story I like to tell, especially as I'm new here. I've been trying to track down Dr. Tom Frazier and work with him for a number of years across other organizations he'd been at. I had signed, 3 different SOWs and MSAs with different organizations he had been a part of, because I am such a firm believer in this approach. Again, being in these conversations with health plans where they are desperate for answers. And Nissa, you had also said, you asked that question around you seeing some providers embed within the report all their citations. I can truly say that a health plan would look at them and say, yeah, that's fine. That's cool. I've got mine that I'm going to lean on. That is advantageous for me in my decision-making process. You can all fill in the gaps as to what advantageous for a health plan may or may not mean. And so how can we at CR sit right in the middle by, again, using those technologies to say, no, here's the research and the literature that which we're going to lean on that is reliable, been updated, it's tested, peer-reviewed, it's empirical, published. And the health plan, again, this is part of my responsibility, is now disseminating that to the health plan. And Dr. Frazier and I have already started having conversations with a number of health plans around this. And so disseminating that, so then coming back to the provider, when they're using AIM, or they're using CR Enterprise, or they're using Assessments 2.0 as that's being rolled out, that helps them to know, okay, as long as I'm using this, the health plan is cool with it.
Aligned.
It doesn't need to be this acrimonious relationship between us, and we can get what we need.
Will this change that peer review process? Do you think we'll see less going to peer review?
That's a great question.
Yeah, in my ideal state, you would not have to do that anymore.
Yeah.
If we can accomplish what we're setting out to do, and I firmly believe and I'm confident in this, the goal is to try to get out of the prior auth UN process. And now how can you change and shift the dynamic around how healthcare is delivered? And so rather than bogging it down the administrative processes, which none of us got into this industry to become administrative process heavy, but instead you're now looking at alternative payment models, value-based care arrangements as an example, bonusing for clinical progress and bonusing for outcomes. So now a clinician and a provider group can receive higher rates based on clinical progress, transparency, bi-directional communication, potentially with outside stakeholders. If that individual needs wraparound services or referrals, hey, look, we saw that they needed this, and boom, within 24 hours, we got them over to other levels of care that's applicable given the assessment outcome information. Cool, now we can give you a differential reinforcement of dollars and cents based on that versus, hey, go out there and bill 2 more hours so that we can get a little bit more money.
Gosh, this leads me to, I have so many thoughts in terms of the listener right now. And they're like, hey, I'm an organization leader. This is exciting. I want to go down this path. Let's have a conversation versus I'm a BCBA. Well, what do I do? I think the answer is if you're a leader, you're the one starting these conversations, moving in the path of setting up your organization to do this. Whereas if you're a BCBA, you're waiting to see if you become involved, if your organization participates, because back to your point, it sounds amazing, right? We can do the work we were trained to do and remove the administrative requirements that I go back to. I heard Dr. Rick Kubina talking last week about pajama time and using AI, right? That a lot of us do our session notes at the end of the day. It's pajama time. We're doing it. If we don't do it and we're going back to back in sessions, we've got to write our notes later. And all of the components of, and I think we've talked about this on the podcast before, writing a treatment plan and that reauthorization and the hours of pulling the data, reviewing the data. So for BCBAs, if this is the path their organization decides to participate in, it sounds like they can go back to being the clinicians they were trained to be.
That's right.
With
That's
less
right.
requirements.
Yeah. Sorry to interrupt you there. I tend to get very excited. I'm sure you can all tell when I talk about this. Part of that so when I was at Magellan, we were the first ones to implement value-based care in ABA. And we had done it with a provider on the East Coast, got our feet wet there. And then we did it with a provider on the West Coast. That West Coast provider, it was actually a multi-year arrangement. And a stat that they said to me that really stuck out, and I think that the listeners on the other end here will find fascinating, is they had 100% retention of their BCBAs for those BCBAs that were involved with the value-based arrangement, because they were then paid for indirect work. They were paid because they were on an alternative payment model that allowed them to take a step back and say, I can actually call the PCP and I'm not being punished because it's a non-billable work. The CPT codes say that for supervision, everything has to be direct and observable with the individual present. But if you can call the PCP, you can arrange a meeting with the teacher or the school staff, you can have those conversations with everybody else within the medical model. That's how we want to be as clinicians.
That reminds me of way back in the day when I worked in California for Regional Center, and we were able to have team meetings with all of the technicians and the parent, and we would all run our probes and we get to see how Nissa would do it versus Olivia and engage in those really comprehensive team meetings that benefited the client who was sitting in the center of it all.
Those H codes, those were nice. H codes were nice back in the day. Yagnesh, I wanted to ask you, this sounds amazing. I think, again, playing the role of the clinician listening to this, it sounds ideal. Like this is what we all would like. What do we need to do as clinicians to be sure that we're doing it correctly or doing it to follow all of these, best practice guidelines to get the most out of it, but also, of course, still having good, strong, ethical, individualized care?
Olivia, it's a really good question, right? Like what can we start to do in the immediacy? And I think truly in the immediacy, you can look at what the research and the literature indicates, right? You can look at what the output of AIM citations are because all that is available. It's all accessible. You can get out there and look at that, right? And so I think it's a great start is to become more familiar with the research indicates.
Okay.
One. And I think two, hang in there with us and don't be reluctant to ask questions. Don't be reluctant to ask hard questions. Just last week, I had a conversation with a different department within Central Region. Majority of the department are behavior analysts, and they were firing away questions at me. And I want them to do that. And I want the industry to do this, right? I want people to ask these hard, challenging questions, because if we are truly going to embark on this paradigm shift, we have to make sure that we're asking all the questions we can so that we feel comfortable with this.
I'm curious, and I know you can absolutely not answer this question, but how is that conversation going to go on the payer side? I know that you are here to do that, to start engaging. My background and experience with payers is truly submitting my treatment plans, going to peer review. I've been maybe twice in my experience. It hasn't ever been egregious or terrible. It's just been a very run of the mill. So my question is truly out of curiosity. How does one begin that conversation armed with literature, armed with technology and support? What does that look like? How do you get on their calendar?
Just to make sure, are we saying it from my side or from the clinician side?
From your side, yes.
Okay, fair. I've been very fortunate that in my decade plus at the payer side to have a number of health plans that I developed longstanding relationships with. And so if we take a small step back and just evaluate what's in front of us, right? The highest cost in all the behavioral health services is ABA services. The fastest growing pediatric behavioral health condition is autism. So you put all that together, easy to see that there's a rising cost here. Now, everybody who's listening to this, I would say everybody who's listening to this, myself probably included, is probably going to say to themselves, I don't care that the health plan has to spend more money for this. I don't care. Not my problem. We pay our premium. You have to pay us. And I get that. I truly understand and I get where people are saying that. But we also have to be equal participants and equally good stewards of the healthcare system. And I think that's an important part. The healthcare system, as currently constructed, if it continues to go in the direction it's going in, is going to continue to be bankrupted. Now, absent of a complete radical shift in how the healthcare delivery is provided in our country, some people, myself included, says that we need to get down there eventually. But since we're not going to get there within this current construct, how can we do this differently? Part of that is by having a conversation with a health plan to say, not only can we consistently and reliably provide to you what the outcomes and the hours need to be, I can also then work with your actuaries to understand what the consistent cost is going to be. Because so now from a cost, at a macro level cost perspective, if you're able to map out from an actuarial perspective, you take penetration plus the alternative payment model design. Now you're able to see what the cost of the program needs to be each year. Well, now we can fund this appropriately. Now we can make sure there's enough dollars and cents, because when a health plan doles out its dollars and cents each year, they're not saying, okay, there's X amount of money for ABA, there's X amount of money for ECT, there's X amount of money for outpatient services. They're not doing that.
Yeah.
They're saying, here's all the money. But if we can make sure that ABA is designed in a way where the cost is predictable and the outcomes are becoming predictable, now we can shift it to say, here's your money, here's your dollars and cents. Now we can better fund this because the health plan knows that recommendation that's coming their way meets medical necessity.
So we're building really a partnership, a true partnership, versus in the past, it was that fee for service. We're submitting requirements. We're going to peer review. And for lack of a better word, sometimes when you go to peer review, it becomes almost like a battle for hours, right? A battle for funding and support. Mm-hmm. And we're hoping to bridge that gap by saying we're now going to be a team working together, and we're removing that kind of battle type language.
And you're removing the administrative process that both the health plan and the provider has to go through during this challenge, right? Trying to figure out each and every, okay, who am I submitting to? Where do they like their I's and their T's, right? We don't need to do that. It's just silly.
All the different types of templates and requirements within the submission.
All of that. Exactly.
Yeah. It seems like we're shifting more from show up every 6 months to prove it to we're going into it already with our mutual understanding of what we're looking at, what we're going towards. I worked on the payer side, briefly as a clinical reviewer, and that is what it was. Every time I would speak to a BCBA, I was asking them the same questions, and they were having to reprove every 6 months. Like, I promise we're making progress. Like, I promise these goals are what we need to be doing. And they were getting a different reviewer every time, and, all of that kind of stuff. So it definitely sounds like in this model, we're on the same page from the initial assessment authorization, as opposed to having to reprove every 6 months.
Right. Exactly. Literally.
So on the flip side, there's one role we haven't talked about during this, and I can't even believe we're almost up on time here, but that's the perspective of the family or the parent.
Yeah.
From what I'm hearing and for what I've learned in the last few months of outcomes-based care, the family, the client, they truly stand to benefit from this collaborative effort. Do they continue to be as involved as we've seen in the past? Because you hear about leaving parent training hours on the table, or there's a requirement for parent training, but some parents are working. They might have a couple of jobs where they can't participate, and then the provider gets dinged for not utilizing those hours. In an outcomes-based care model, I foresee or imagine that this is truly if the parent can and they are available to, they participate as much as the behavior analyst trains and supports them to. And if they are unable to, no one is penalized for that. Am I making the right assumption there?
You are. And I think this is also something that in my conversations with not only health plans, but also state regulators around ensuring that's happening, right? That social determinants play a massive factor here. Mm-hmm. And so not penalizing a parent for a lack of parent training, but truly finding out why.
Yep.
Through social determinants of health, what are the barriers for the parents to be able to do that? And Elizabeth, you had mentioned at the very beginning, 7 dimensions of ABA. Generalization, right? And what are the barriers for us to be able to ensure that generalization can happen? And one of the best ways for us to demonstrate generalization is through parent training and parent modeling. But if the parent's not available for any host of reasons, most of which you mentioned as well, Nissa, how can we ensure that clear line of communication is happening between the provider and the health plan to know, like, okay, it is what it is, right? And that's often the times in healthcare, right? Like that parent, one of the stats that always stuck out with me is that a parent with a child newly diagnosed with autism has the same cortisol levels as a veteran who's just returned home from work. How do we ensure that within this entire structure of the payer and the provider and central reach, that family is right there at the middle? That everything which we do has to be for that family and for that child right there in the middle. And that nobody can pull one way or the other for their own gain, because that family has to be the foremost priority for all of us in these conversations. And so what is the parent's responsibility within this? It's going to be exactly what they're doing now, but through transparency of what the outcomes look like, through transparency around what the goals need to be by saying, here are the deficits and here's what we're going to work on. Now the parent knows. And I can say as a parent, and I'm sure many of us can say as parents as well, we just want to know the truth about where our child is so that we know what can I do differently and what can I do better? And I think, unfortunately, sometimes in the field of behavior analysis that we lose sight of that, right? In that the technologies that should be easily understood and digestible from that family's perspective doesn't necessarily happen each time. How can we shift that?
That's so important. And I know we're running short on time. I feel like we could talk about this for so much longer. We might have to eventually in the future. But going off of witness that you mentioned, of course, requirements for caregiver guidance, parent training, whatever you want to call it. Do you anticipate any other requirements changing in this process? Autism diagnosis, location of services, coordination of care, any of those other requirements that are typical in fee-for-service right now? Do you anticipate those shifting in this new model?
I think we're going to have to continue to see what the data looks like. And that's something that I've long been very firm about and ultimately this was my biggest hang up when I was at Magellan, was I didn't have enough data to be able to make that informed decision around the direction and that we needed to take. That's what makes Central Reach so unique, is the amount of data and the information that Central Reach sits on to be able to make those informed decisions as we go forward. And Olivia, what we want to be able to do is take what the data is indicating, take what the assessments are indicating, and if we need to then shift and go into a different direction based on that, I think that's something that, again, transparently, we should be able to do because, again, the numbers are going to be there for us.
Yeah. I do love a data-driven approach. That's something that we talk about on our team. We can't make decisions on what people need until we gather that data.
Yeah.
So going back to the parent caregiver coordination, parent training, parent empowerment, all the different terms that we use, I'm imagining this new world of providers being able to talk very openly with parents in their organization about what the shift probably wouldn't change dramatically for the child experiencing the services. We will continue on as is in terms of treatment, if it's in center, in home, out in the community, but the conversations might be more broad in regards to the focus of care, the ability to bring the parent in more frequently or less frequently, but have more open conversation, having more team involvement at that level. With this model, will we also start looking at collaboration and coordination of care with other providers like SLP and OT? Will those be bundled in as well?
Yes. And that's a beautiful part about an alternative payment model, right? Is that now you can go out there and be creative with those other levels of care. And that's what should be expected of all of us within the healthcare delivery model. If you look at the overall health model of care, what you want to be able to do is wrap around all of those services. And frankly, like something that has long challenged ABA providers is, why do I have to be that one to be able to wrap around those services? Like, why do we have to be the one to do that? Why can't it be somebody else? Health plan, why is it not you? And sure, there are certain components within the healthcare model, for instance, like complex case management that many health plans have to mandate, and they do cover based on an individual's complex needs, if they're severe enough, et cetera. But with our alternative payment model, where you are given, say, a capitated rate, a set dollar amount each month, as an example, now you can go out there being creative and have those conversations with the SLP, with the OT, with the psychiatrist, with med management to ensure that the medication that which we're implementing, just get a better understanding of it, right? None of us has a psychopharmacological background as behavior analysts, right?
You're not, yep. We should not be touching any of that.
No.
We should not be touching it. But what we should be doing is having a better understanding around what that medication is.
Yep.
Should it be administered episodically? Should it be administered 2 or 3 times a day? What happens when it's not being administered on a consistent basis, so that I then have an understanding when I'm looking at my graphs to see, do I need to put a phase change line in there because the medication was not administered over the weekend? Like, I know this from my own family, right? Medication is not administered over a weekend for somebody. Fine, that's a parent's right. Then what should we expect on Monday and Tuesday when medication is now administered? These are the kinds of questions that you can now ask and dig into under this different model.
finally having some time to dig into those things that under the current model are non-billable, that we try our best to get to, but at the end of the day, if it doesn't happen, it doesn't happen.
That's right.
This is a great conversation. I know we are coming up on time, so I definitely wanted to pause. And one of the great things about these podcasts, dependent on your feedback for all of you viewers and listeners, we would love your feedback to hear. We can bring Yagnesh on for another conversation, which we probably will anyway, because we can shift to another topic. And as he gets his feet wet and more ingrained here at Central Reach, we'll have more conversations to have about this topic. As we start to close up, where's everyone going next in terms of work? So one of the fun things we used to do last year on the Behavioral View is just say, where will you see me in terms of conferences, any courses that we're working on? So I'll turn it to you first, Olivia. Anything that you want to share with the listeners in terms of where they can get more content from you or hear more from you?
Yeah, of course. I mean, right now, of course, the big focus is RBT PDUs. So, those will be coming out, and always doing content, of course, on, those important soft skills, compassionate care, all of those kinds of things. But yeah, I think the big focus right now is those RBT PDUs. And of course, that beautiful RBT 40-hour course that we rolled out as well. So you can always find us there. Our faces will always be.
I'll just second that. RBT PD, RBT 40-hour.
Find more Olivia and Elizabeth. You can catch them in the 40-hour RBT course. And Yagnesh, where can people find you? Any conferences, anything coming up for you?
I intend on being at CalABA, and I'm also not speaking at CalABA, which somewhat is rare for me. So it'll be nice. I'll be out there. Whomever may have questions, thoughts, ideas, criticisms, feedback, whatever it may be, come find me. I'm the only Yagnesh typically at any conference, so it's easy to find where I'm at. And I'll also be at CATS, and I'm also available via email, via LinkedIn, however you may need me.
Perfect. And I will be at CalABA this year, APBA and CASP. So if you are interested, I can connect you with the team here, but happy to support your learning. And you'll also catch me on the 40-hour RBT course. And I've got a course on navigating difficult conversations that I need to record, but that should be available to you if you are a CR Institute customer. All right, everyone. Thank you for tuning in to episode 2, season 6. And we do hope to hear your feedback. If you are here to gain a CEU for your attendance, make sure you complete the quiz and you can gather your CEU there. Thank you for tuning in. We'll see you all next time. Thanks for joining us on the Behavioral View. We appreciate your time and the heart you bring to this work. If you're here for a CEU, just take the quick quiz to wrap up. Let's keep talking. I'll see you next time.